Good morning, all of you. Glad to share a few moments with you on the clinical utility of the fourth universal definition of myocardial infarction, thanks to STEMI India. First of all, why do we need a universal definition? We have to ensure that we mean the same thing when we use the same word. All of you are very familiar with this famous statement issued by the American president in the court. It all depends on what your definition of the word is. The same thing we have to understand across the world, trans-Pacific and transatlantic, we ensure that we mean the same thing when we use the same word. So the attempts to define myocardial infarction started quite some time back from 1958 onwards, and we have presently landed up in the fourth universal definition of myocardial infarction, present in 2018, where all the organizations of the world have come together to work on this. Now, the key points of fourth universal definition of myocardial infarction for the first short period of this presentation. Myocardial injury is defined as elevated cardiac troponins more than the 99th percentile of the normal values. If there is a serial rise and fall, it is defined as acute. And if the cardiac troponins do not change more than 20%, it is deemed stable and chronic. So acute myocardial infarction is a clinical definition with acute injury plus evidence of acute myocardial ischemia. This definition has three key elements. It has a pathophysiological basis, it has a clinical basis, and it has a biochemical and laboratory basis. What we have to understand is it is just a definition. It does not provide guidelines. It does not provide clinical pathways. However, it does provide a possibility of us using it in clinical guideways and pathways to improve it. So coming to troponin rise and fall and stable, these are the two big differences. If the patient has a rise and fall with acute ischemia, we label them as acute myocardial infarction, which could be type 1 if it is related to atherothrombosis due to plaque rupture or plaque erosion. If the acute myocardial infarction is related to oxygen supply demand and imbalance, we call it type 2 myocardial infarction, which could happen in hypertension, tachyarrhythmia, and multiple reasons which we'll touch upon. If this rise and fall happens without acute ischemia, we call them acute myocardial injury. Examples would be acute heart failure, myocarditis. If the troponin levels remain stable, we call them chronic injury. The examples again could be structural heart diseases and chronic kidney injury. This graph shows the rise and fall versus less than 20% variation. Many conditions like anemia, hypoxemia, hypotension, etc., they have an overlap of all these areas. They can have no injury, or they can have only injury, or they can have myocardial infarction also. This diagram just to tell you that these are the various conditions that can lead to either injury or infarction or nothing. So how do we differentiate? These are some of the troponin rise and fall patterns we'll touch upon in the definitions. As I told you, type 1 myocardial infarction is due to plaque rupture or erosion with or without occlusive thrombus. In type 2 myocardial infarction, there are multiple reasons it could be due to, but there is no plaque rupture or thrombus or atherosclerosis as the cause of myocardial infarction. Predominantly, it is the oxygen supply and demand imbalance. As you can see, in the context of type 2 myocardial infarction, it is always secondary to another illness or process. However, the main reason for presentation will be chest pain. It could be due to, say, coronary embolism, or a spontaneous coronary artery dissection, or a spasm, or a sustained tachyarrhythmia, or bradyarrhythmia, anemia, hypotension, shock, etc. All these things are labeled together as type 2 myocardial infarction. So what is type 3? Any type 1-like picture where the patient has a sudden cardiac death before we could do troponin is type 3 MI. Type 4 is periprocedural. with more than 5 times 99% elevation after PCI. Type 4B will be a type 1-like picture with stent thrombosis related, and type 4C will be a type 1-like picture in the setting of a restenosis. If you have a post-CABG elevation of troponins more than 10 times, we call it type 5 MI. This picture broadly summarizes all the various varieties of MI. Now, what is the clinical utility? I'll show you a couple of studies. A good study by Chapman group, 2,100 patients for whom cardiac troponins were done for any reason were adjudicated using the fourth universal definition of MI. 1/4 of them had myocardial injury, and a large number had a type 1 MI. The primary outcome was all-cause death, and the secondary outcomes were MACE and non-cardiovascular death at 5 years. Let us see what happened there. Though all of them had an equal MACE rate at 5 years, the all-cause mortality was very high in patients who had a myocardial injury, followed by type 2 MI. The graph shows here, the Kaplan-Meier curve shows that the survival free of death was quite low in patients who had a myocardial injury. If you look at the MACE rates here, despite an excess of non-cardiovascular death in patients with type 2 MI and injury, the MACE rates were similar. In type 2 MI, they segregated patients with and without known CAD. A patient with CAD can have a type 2 MI. And those patients had a higher MACE rate, as you can see. At the end of 5 years, the presence or absence of CAD was an independent predictor of MACE or type 2 MI or myocardial injury. Thus, identifying underlying CAD can help to target therapies in these patients which could modify risk. This was another study published 2 years back in 2020. 2,300 patients in the ER with symptoms suggestive of MI. They all were diagnosed based on third universal definition of MI and fourth universal definition of MI. Now, compared to the third one, when you apply the fourth, 1/3 of the patients had to be reclassified. This alluvial diagram tells you those who were classified as non-coronary cardiac chest pain, a significant percentage of them had chronic myocardial injury. A good number of them had unstable angina. Some of them had acute injury, and many of them had type 2 MI as well. If you look at those classified as cardiac but non-coronary chest pain, a good number again had a chronic injury. Overall, just 30% were re-adjudicated. And if you find that the patients with acute myocardial injury and patients with the chronic myocardial injury, they had a very high hazard ratio compared to type 1 MI. Those who had reclassified, if you look at the curve here, those who had a reclassification had a very high risk of cardiac rehospitalization, death, and MI. Thus, this fourth definition helps us to identify very high-risk patients whom otherwise would not have been identified. Another study published last year where the ability of Gray score to predict 1-year mortality of the fourth universal definition, type 1 and type 2, was tried. And what they found that was Gray score was having a good predictive value in type 1 MI, but not in type 2 MI. So now, based on this information, what we understand is, if we need to use the Gray score to risk stratify a type 2 MI, it needs to be recalibrated. Thus, this definition helps us to identify the appropriateness of a clinical score to use risk prediction. But however, what we have really found is the diagnosis part of it. We have made significant progress, but the management part of chronic myocardial injury, we really need to have a good progress in the days to come. So this is the area how we need to work on. This myocardial injury is an area where we really need to have a lot of studies to find out how our patients really fit in, how our studies can help to identify and manage these patients with myocardial injury. So does it need a reclassification? There are a couple of questions that were asked. The reason being, if you look at the type 2 MI, we know that those who have a fixed atherosclerosis have a higher risk. But it also includes these groups: spontaneous coronary artery dissection, coronary embolism. These typically present like a type 1 MI. So the thought was, can we pull them together as type 1 MI as 1A, 1B, 1C, 1D? But however, we have not really found that was clinically useful. So what we have is the usual presentation of type 1 myocardial infarction and type 2 myocardial infarction, where we include all these three. So what we have to understand is the word type 2 myocardial infarction includes a lot of conditions with different pathophysiological basis. However, they all have a high risk of adverse cardiac events at 5 years. So coming to the end, so what do we learn from this presentation? The fourth universal definition of myocardial infarction brings in a university in defining myocardial infarction across the world. So we can pool data together, combine researches, particularly in the area of type 2 myocardial infarction injuries, where we need to really make a lot of management guidelines and pathways improving the outcome. This helps us to identify the high-risk subgroups which had not been identified before, as we saw in 2 studies. This also contains sex-specific cutoffs. Thus, we can identify high-risk women who otherwise could have been missed out. As you know, the N-TIL phenomena is so common in the cardiology world. And this definition is likely to influence all the investigation pathways and the management guidelines in the time to come. And thank you very much for the patient listening. Thank you.